Good morning. I'm Lee Goldberg with the National Academy of Social Insurance. Welcome to our symposium on the issue of pricing power in healthcare markets. The National Academy, for those of you who are unfamiliar with it, we're a nonprofit, nonpartisan organization made up of the nation's leading experts on social insurance, and our mission is to increase public understanding of social insurance and how it can increase income security and economic security. We're also a think tank. We pull together panels of experts to address important issues in the field of social insurance, and we engage in educational work with young professionals and interns here in Washington and throughout the country on issues facing social insurance and social insurance programs. Today we're releasing the final report of the Academy's study panel on the issue of pricing power in healthcare markets. It should be in your folders. This project is possible because of the funding from Robert Wood Johnson Foundation, the California Healthcare Foundation, and the Jane Koskinas and Ted Giovannis Foundation for Health Policy. And we'd like to thank our funders for their support. The study panel that produced this report is a group of 16 people, nationally respected economists, lawyers, executives from the health insurance and healthcare sector, and healthcare researchers. Our deep appreciation to those folks. They're listed in the report. Very busy folks who nevertheless found the time to be on endless conference calls and face-to-face meetings and go over multiple drafts. And we appreciate the time and the quality work they did. So in terms of our agenda today, it's a short program, and there's two parts of it. First, we're going to hear from Bob Berenson of the Urban Institute and Bill Hoagland from the Bipartisan Policy Center. Both are board members of the National Academy, and they co-chaired this study panel that produced the report. Their ability really to attract experts from a variety of fields across the country and their deep thinking on these issues were critical for both framing the direction of the report and the contents of it. And so the National Academy is particularly thankful to them for their efforts. After that, we're going to be joined by Jeff Goldsmith from Health Futures, who's a member of the Academy, a member of the study panel, and who we commissioned to do a paper on the benefits of integrated delivery networks and what do we know about that in terms of the benefits to society and the benefits to providers. There are copies of the report that Jeff and his co-authors, Rob Burns and Aditi Sen from University of Pennsylvania's Wharton School, and Trevor Goldsmith, also from Health Futures, collaborate on. There's copies outside. And then we're going to have something we're going to switch modes up a little bit, have something different. We're going to have a discussion with a panel of experts on the broader set of issues that this report raises. The discussion will be moderated by Laurie McGinley from the Washington Post. A couple logistical details. We have, as I said, copies of Jeff's paper out in front. We also have copies of a paper that the study panel commissioned that was done by the Catalyst for Payment Reform, looking at state efforts to pass regulatory and legislative initiatives that would improve competitiveness of state healthcare markets. We are webcasting this event, so if you come up for the Q&A afterwards, please identify yourself and any affiliation. And then finally, our communication team is live tweeting this, and we welcome everybody to join in that conversation. We're using the price tag pricing power, and we hope to get a lively Twitter conversation going. So before I turn over the mic, I want to address sort of one issue that maybe folks are wondering when they got an invitation from us for this event. Why is the National Academy of Social Insurance an organization that in its healthcare work has really focused on Medicare and programs that help achieve universal coverage? Why are they looking at pricing in private pay healthcare markets? And I think the reason is pretty simple. We all know Medicare lives in a broader healthcare ecosystem, and its spending and its ability to set prices is affected by the commercial market. We see that in the MA plans. We see that with Part D. And we even see it in the hospital reimbursement, where groups like MedPAC are looking at total hospital margins and taking into account private reimbursement. So it seemed like a natural issue for us. So I think now I'm going to turn over the podium to Bill Hoagland, one of my many bosses on this project.
Thank you, Lee, and particularly thank you, Lee and the NACI staff for your diligence over the last many months and last 2 years, in fact, in bringing this work to fruition. Good morning, everyone. I'm Bill Hoagland. My day job is at the Bipartisan Policy Center, if you can believe it, bipartisanship. But today I'm here as both a NACI board member and also as the co-chair with my friend Bob Berenson on this project. In June of 2013, the National Academy convened this study panel on evidence that they thought high prices in the United States explain much of why per capita spending on health care is so much higher here than in other developed countries. Further, that in many areas of the country, higher prices are the result of market power defined as the ability to raise and keep prices higher than would prevail in a competitive market. My fellow co-chair, Bob Berenson, along with Paul Ginsberg, have written, by the way, Paul is a member of the study panel, have written extensively on this, that the market power of providers varies widely across regional and metropolitan markets, measured both in terms of payment rates and claims data. Now, price variation by itself is not a problem, but when the variations are unrelated to the quality of care, the acuity of the population served, the payer mix, or the status of an academic, teaching hospital, or research facility associated with the hospital, I think they are a problem. And unfortunately, we have found that these variations among private payment rates are all too often explained by the differences in the negotiating leverage of regional hospitals and physician groups, not in the triple aim goal we all have for seek improved quality of care, consumer satisfaction, and all, of course, overall lower costs. Now, to be clear, this study panel recognized that health plans can and do use their market power to leverage higher prices. Historically, the health insurance market has been highly concentrated, and that's a legacy coming from the local Blue Cross Blue Shields. And there is some indication recently that there has been an uptick in increased concentration in the health insurance sector. And in fact, there is some who suggest that increased concentration there may be the result of a countervailing effect of resulting in increased payer concentration. But overall, the study panel did not find that evidence of insurer consolidation producing market power to be that strong. We discussed this in the report and highlight the mixed messages from a number of studies. Indeed, we discussed one that found that hospital prices in the most concentrated insurance markets to be nearly 12% lower than the more competitive insurance markets. While concerns about insurance market power exist, and our policy options do not ignore payer market power, the panel was more focused on the shifting balance of market power from private purchasers to healthcare providers over the last 2 decades. Given the continued increase in horizontal and vertical integration of hospitals, the panel felt there was a need to understand the impact of this continued consolidation on prices, and to explore those policies that address those higher prices of hospitals and physician prices. In the past, we have seen analysts, researchers, and decision makers offer proposals to address weak and non-competitive healthcare markets through a variety of policies that often lack policy coherence. Hopefully, this report we are issuing today can provide some policy coherence as we examine an array of policy options and explore their advantages and disadvantages. Let me also highlight a conclusion I personally reached as not the expert like many here in the room, but as we work through this study. It's not profound, and it's probably obvious to most of you, but it deserves emphasizing. Much like what was it Tip O'Neill used to say, all politics is local, I have concluded all healthcare is intensely local. And I would add, however, another former speaker, Speaker Gingrich, would add to that a caveat and say local unless you are wealthy. But overall, competitiveness of local and regional markets varies significantly, and what works to increase competitiveness in one market may not work in another market. Some policies may have clear disadvantages. For example, in a market that is already highly concentrated, it is difficult and challenging to find policies that can be taken to restore competitiveness. Finally, the panel faced a number of additional challenges in bringing this study to a completion. It was tough. First, how should one categorize policy options? One person thought of a policy that improves market perhaps more through concentration, more aggressive enforcement of antitrust legislation, outlawing certain contracting practice. Another person could reasonably interpret that as government intrusion. It is difficult to draw a line distinction between these two types of policies. For that reason, the panel found it more useful to look at them in a continuum, ranging from policies designed to foster more market competition to policies that rely more heavily on direct regulatory intervention. Second, while we have a healthcare sector that is based on the notion of competitive markets, there is a clear recognition that healthcare is unique from other consumer services. It is personal. There is an asymmetry of information between buyers and sellers. There is inherent uncertainty and variation in clinical decision making. Overlay this with with insurance protection that most in society would like to have, but isolates the consumer from the cost. And finally, there is the public good component of this market that provides research, education, and caring for the uninsured. How should antitrust competitive policy address this unique market? It is not entirely the same as addressing a market that manufactures widgets, cars, TVs, or iPhones. Some people think the current market failures can be improved or even perfected, and therefore gravitate to public policies that would make markets function better. Those skeptical of market solutions for healthcare tend to favor more overtly regulatory approaches, and some see a complementary interaction between regulation and competition. As a result, the study panel developed, and amazingly, we came to agreement on a set of principles to guide policymakers across this ideological and political spectrums. Bob will discuss some of these principles in a minute. And finally, I must emphasize that the policy options with their advantages and disadvantages in this report as you read through it should not be seen as either a packaged set or a set of competing alternatives. Panel members felt it was important to offer individual policy alternatives, knowing that some may work better in combination than individually, and some may be inappropriate for a particular local healthcare market. No one policy is likely to be optional for all healthcare markets. The proverbial no-size-fits-all solution here. Thank you for your attendance here this morning. Personally, this has been a challenging project for me, but I have been the benefactor of the project, listening and learning from the distinguished study panel members, and particularly my co-chair, Bob Berenson. And so now I welcome Bob to discuss some of those principles and provide an overview of the policy options we reviewed. Bob?
Thank you, Bill. And it has been my pleasure to co-chair this with Bill also. This, as mentioned, has been a challenging project because we were essentially starting with a blank slate in terms of policy options. In recent years, there has been increasing research and reports about the problem of high and variable prices in the healthcare system, but pretty much a blank slate in terms of looking at the array of policy approaches that could be taken to address it. And that was our primary objective, was to sort of at least put a default typology of policy approaches on the table. Clearly, they need to be improved. We need to do deeper dives into our pros and cons. We could barely scratch the surface of the advantages and disadvantages of each, and those advantages and disadvantages will clearly vary on the particular circumstances. And as Bill said, healthcare is local. What might work in one state or community is unlikely to work in another one. And so that, again, was part of what generated our interest in this, was to provide, in a sense, a menu of possibilities. Right now, I'm not going to go through the pros and cons of and the specifics of what we propose. I'm going to mention a few to make a few points, but that's what the purpose of the second panel will be, to actually have a discussion about strengths and weaknesses of different approaches. I want to make the point that the issue of pricing power has, in fact, been largely ignored amongst the broad policy community. Although of intense interest, obviously, to the federal antitrust enforcement agencies, the FTC and the Antitrust Division of the Department of Justice, and increasingly to states' attorneys general. As our options make clear, antitrust enforcement, while essential, is only one tool that policy can take. Our recommendations emphasize the range of options that policymakers, and most of these would probably apply at the state level rather than the federal level, many of the options, but a range of options that policymakers can take. As Bill was emphasizing, given the great variation in healthcare markets and underlying social and political cultures, there is no single easy policy fix for the nation for this on this issue. Our goal, again, was to array the possibilities for consideration and understanding that all that we have presented would have to be adapted for the local culture, the local political environment, et cetera. One point I want to make about the, when you see and have a chance to look in more detail at the policy options, one point to keep in mind is that currently marketplace participants on their own are acting outside of any directives from government to address this issue of prices. For example, narrow and tiered provider networks are being implemented, certainly in the exchanges and to some extent in large group insurance. One of their purposes is to increase payer leverage in negotiations with providers, in essence, getting some price concessions in exchange for volume. So this is going on. Narrow networks, tiered networks are going on. It's not a policy to decide. It wasn't our mandate or choice to say that we should or shouldn't be having narrow networks. What policymakers have to be concerned about is whether they should put constraints of any kind on narrow networks, and one of those tools would be how they implement network adequacy provisions, for example. The tool that the policymaker has is not the decision to move to a narrow network, but it is to decide whether and how to limit the application of that initiative. So there are things going on in the market, and we do not in any way want to imply that all action on this issue has to be generated out of government, whether federal or state. And indeed, there is recent data coming in that suggests that provider pricing, specifically hospital pricing, has been relatively flat in the recent past. So that does raise the question of whether there are some natural self-corrective mechanisms. That's all what makes this a difficult issue. None of the policy proposals that you will see are particularly original, although a lot of them are not well known. We purposely sought to identify ideas that exist in the real world, have been tested to some extent, although sometimes not, as I say, well known to the general health policy community. That again has come relatively late to this issue of provider and insurer consolidation and pricing power. And indeed, a colleague of mine at the Urban Institute, Randy Boberg, and I recently did a study of the North Carolina Certificate of Public Advantage, which oversees the merger that occurred 17 years ago of a hospital system in Asheville, North Carolina. It's a sort of a state action regulatory oversight of that merger. So out of curiosity, I asked a number of very prominent, very skilled, very expert health policy analysts and researchers if they could tell me what a certificate of public advantage was. And I had one out of about 25 that I polled. One of our goals is that as part of the general health policy discussion, terms like certificate of public advantage, state action immunity, the difference between structural remedies and conduct remedies, those are antitrust terms. They should be part of the discussion. But a number of the other things that we are proposing, I think, should be part of the discussion on this sort of central issue in healthcare spending. Much of the limited discussion about how to address payer and provider consolidation and resulting high prices tends to focus on pure models, either of competition or regulation. On the one hand, break down all barriers to entry, make it all transparent, create consumer markets with cost sharing and robust quality metrics. Or on the other hand, all payer rate setting, and now in Maryland, all payer global budgets, which emulate or in some ways even lead what most developed country healthcare systems do to address pricing. Most other countries actually sort of regulate prices. One of our goals was to fill in the space between these polar alternatives, but understanding first that one may need to regulate markets, such as via vigorous antitrust enforcement, to make them work well. And second, that one can still promote meaningful competition among providers and health plans even when unit prices or budgets are regulated. These are not necessarily, once you get into the real world, they are not necessarily pure polar opposites. I guess what I'm saying is that pure models of competition or regulation should not necessarily be viewed as the gold standard. In short, the real world doesn't neatly sort out along ideological lines. We discuss incremental approaches with perhaps limited but real potential in this messy reality. So we include, for example, these are just examples, items such as a commitment to increase transparency of prices and other relevant information, including through all payer claims databases. Statutory prohibitions on particularly one-sided health plan provider contracting provisions, such as all or nothing contracting, where a hospital system negotiates on behalf of all of its hospitals and not one by one. Some states have moved in that direction. Enhanced public oversight and review, such as represented by the Massachusetts Health Policy Commission, sort of a body that has responsibility, perhaps not a lot of authority, to shine a spotlight on the issue of costs and prices. We talk about the potential pros and cons of placing upper limits on permissible payment rates achieved through market negotiations. So short of an all-payer rate setting system, just saying there's a point beyond which prices can't go. Again, none of these are layups. We have a broad array. Bill mentioned the policy principles. I don't have time to go through it. I do want to emphasize this point, that the group met with the express purpose of simply coming up with policy options and a logical frame for presenting those options. And the committee as a whole, in a sense, rebelled against that limited objective. Certainly, we should have some recommendations. We were not in a position to say, here's the menu of things that government should do today. But what we did do, and this again was generated by our committee members, was establish a set of principles that we think can guide the development of policy in this area. I want to mention just three. There are more in your packet. Market competition is the best way to motivate providers to increase efficiency and improve quality. Where market competition is ineffective, public policy can enhance market competition, or if that is unlikely to succeed, regulate prices directly. In other words, the issue is too important to just let it proceed on its own. So take some action is essentially what that is saying. Significant price variation should reflect real, tangible differences in costs, organizational missions, and consumer preferences, not differences in negotiating leverage among insurers and providers that put the latter in financial circumstances unrelated to their performance. In other words, used in a different context than the question of how is it that the manufacturer of Sovaldi, the hepatitis C drug, can charge $84,000 for a course of treatment? The answer, because they can. That seems to be, at least in some situations, how prices are determined. Prices are what they're not based on costs or not based on market demand, but it's a result of competitive leverage in negotiations. While the emergence of payment reforms and delivery systems such as accountable care organizations may improve quality, it can also contribute to excessive market consolidation. I'm reading a principle now. The known costs and benefits of new payment systems should be evaluated before making exceptions to competition law. Some of us on the panel are, in our other work, have written about and studied the potential of aggregated provider organizations, consolidated organizations, perhaps on the one hand to improve quality and efficiency, but perhaps not passing through those efficiencies back because of their ability to get high prices. I actually think the specific payment models that are adopted can go a long way to addressing that concern. But again, the point of the principle is that not all of the innovation, I guess the general point is that we should be looking through the lens of what's likely to happen to pricing power as we move forward on these new models of care. And with that, let me introduce the next part of the program. One of the most talked about new delivery models is the so-called integrated delivery network, which is probably the most ambitious form of vertical integration, often consolidating into one large entity, hospitals, post-acute care facilities, physicians, and other clinicians, and sometimes even the insurance function. Claims for IDNs as the logical approach to achieving higher quality and greater efficiency are made by advocates, and concerns about the aggregation of market power into powerful oligopolies immune to market forces are raised. So we commissioned a paper. Jeff Goldsmith is the lead author, the principal investigator, to explore what is known about IDNs. And with that, I want to turn over to Jeff. I will be seeing you again on the next panel. Thank you for your attention.
Thank you, Bob, very much. Good morning to you. I was asked to join this panel in part because a lot of my professional background involved creating integrated delivery networks and trying to help optimize their performance. Unlike a lot of the folks in this room, I'm a business person, 33 years in strategy consulting and advising large complex health organizations on what to do. And when I joined the panel, there was a lot of concern about hospital pricing power, and yet I know most of the markets that people are worried about. When I joined the panel, what I said immediately to them was, you realize, of course, that the people that own the hospitals in these highly concentrated markets will tell you that it's not their principal business, that they're not hospital companies. If you ask the CEOs, what are you doing? They also own, 1,000-person medical groups. They own health plans. They own distributed networks of ambulatory sites, post-acute and long-term care facilities. These are complex enterprises about which we know almost nothing. And so I was given a modest budget to try and characterize, both from the professional literature and from what we could determine from the public disclosures of these entities, what they're actually doing and the effect that they're having on local markets. And of course, consultants have to have PowerPoints, right? I only have 5. The animating vision, I mean, Bob said this is a new idea. It isn't a new idea at all. It's a 70-year-old idea. Kaiser Foundation health plans, of course, were the template. But since the HMO Act of 1973, we've had 4 waves of creation of these entities. The policy advocates for this idea believe they are, quote, a cure for the fragmentation that characterizes our health system. And their real mission is to coordinate care across the continuum and to improve quality and lower cost through that coordination. That managed competition idea involved creating multiple Kaisers in each metropolitan market. So a lot of my consulting work was in Kaiser's markets, trying to create a Kaiser-like entity to compete with them, because that's where we thought health policy was going. Of course, in Elwood and Enthoven's model, these entities would be paid by accepting a premium, and that consumers would choose a system, and when they got the system, care would be coordinated inside it. The patient's role was mostly to choose the most cost-effective IDN and then stick with it. My colleague Rob Burns at Wharton, who was a student of mine at the University of Chicago back in the day, had spent the better part of 30 years studying these critters, and his role in this study was to look at the literature, and it's remarkable how little evidence there is in the 30-plus years we've been studying them that they actually do what their advocates claim. There is no evidence in the academic literature that these entities either lower cost or improve the coordination of care, or that the quality of care is higher. Physician-hospital integration, which has been a major driving force of these organizations, I mentioned, of the 15 organizations we've studied, 9 of them have physician groups bigger than 1,000. That is an enormous physician enterprise. The evidence thus far is that physician management by hospital systems, by large integrated enterprises, has raised the cost of physician care on a unit basis, raised hospital prices, and also raised per capita spending. Jamie Robinson's recent paper on this subject. That the sponsorship of health plans, which is the vehicle by which these entities would market their services, has been a significant net loser to most of the sponsors. There have been 4 waves of provider-sponsored health plan development in the last 40 years since the HMO Act of 1973, and a failure rate of 5 and 6 is pretty much the norm. 7 of our 15 sample IDNs had their own health plans, and 3 were starting them. So we had a pretty good look at that dynamic. And the big problems with those health plans have been achieving critical mass of enrollment and crippling adverse selection. In other words, they tend to recruit their own patients into the system and therefore get a sicker population than their premiums will support. So there have been consistent and intractable problems in entering and in managing that problem. We, on a very limited budget, took a look at 15 nationally prominent IDNs. We basically assembled a data archive of all the publicly available literature on them, their Medicare cost report information, their disclosures to bond rating agencies, the Leapfrog Group, Healthcare Compare, the Medicare site that contains Hospital Compare, the Medicare site that contains quality information, the Dartmouth Atlas. I mean, anywhere we could find either IDN-related or hospital-specific information for IDN hospitals, we assembled the data archives and looked at them. I guess, you know, our top-line conclusion was, from a standpoint of public disclosures, these entities are enormous multi-billion-dollar black boxes. It's almost impossible to tell what percentage of their revenues come from the hospitals that they own, let alone, and in none of the cases could we actually tell how much profit those hospitals were generating. They were buried in the disclosures. One of these organizations, a famous nationally prominent IDN, has a single-page P&L disclosure with 20 lines. That's it for a vast, complex, very successful multi-divisional entity. The subsidy flows inside the IDNs were completely opaque. In other words, we couldn't tell, where the health plans have to disclose for purposes of public regulation in their states. So you could tell whether the health plans were making money, but the provider businesses, you really couldn't tell anything. You couldn't tell where the profits were being generated in these entities outside of the health plan disclosures. And moreover, no way to tell how risk was distributed in the IDNs. In other words, is the risk held at the level of the health insurance plan, or is it distributed down into the provider networks? I happen to know a lot of the people that run these, and in almost none of the cases is the care system actually capitated. So they continue paying the docs and hospitals on a fee basis or on a unit cost basis, but are charging a premium, a population-based premium at the level of the plan. We did look at hospital market concentration. We were able to obtain the Herfindahl indexes for all of these markets. And there was no relationship at all between the degree of hospital market concentration and the profitability of these 15 IDNs. And in all 15 cases, those IDNs were the dominant actor in the local hospital markets. So if these entities were successfully monopolizing hospital markets, the proceeds of that monopolization did not drop through to the IDN's bottom line. It disappeared somewhere along the way. Bed size and total revenue also did not predict profitability, which contradicts a major story of the banking industry, which is that if you're $6 billion, you're going to be more profitable, you'll have more market leverage. So at least apropos of the concern of this panel, we didn't find evidence of economic gain from these entities having enormous market position in their markets. Now, what we were not able to do because of the lack of resources was to actually go into pricing. So we did not have access to the databases on what Blue Cross or United Healthcare or whatever are paying these entities. But we believe that the best test of whether these entities are actually doing their job is whether the total cost of care in those organizations is lower than it is for care being rendered in less organized settings across the community. Because IDN performance is not rolled up at the IDN level, there's a tremendous amount of hospital-specific information. So we chose as a proxy for IDN performance to look at the published performance of the flagship institutions of these IDNs. Nearly all of them have a flagship. It was in many cases the principal hospital that generated all the cash flow that enabled them to become regional entities. It was really kind of disturbing. We found no detectable qualitative differences on safety or clinical performance between the IDN flagships and the directly comparable market competitors. So like with a large teaching hospital, we would compare it to its main teaching hospital competitor. If it was a large regional multi-specialty group, we compared it to the nearest large regional specialty group. So we were trying to, sort of normalize for mission. But in 11 of the 14 cases where comparison was available, those flagships had higher case mix adjusted Medicare cost per case than their competitors did, even though 5 of those competitors had a higher case mix index, which is a proxy for the complexity of the case mix and the illness burden of the institution. The Dartmouth Atlas has a really interesting measure of the total cost of care in the last 2 years of life for patients attributed to a principal hospital. And this was the closest we could come to that total cost of care criterion that we talked about a moment ago, which we think is the best measure of whether an IDN is really doing its stated job of coordinating care across the continuum. In 12 of the 15 cases, the flagships had higher per capita cost in the last 2 years of life than their market competitor did. And if they were eliminating unnecessary services, it wasn't obvious. 11 of the 15 flagships spent more on imaging. 12 of the 15 had higher lab costs. And apropos of the question of does sponsoring a health plan reduce the total cost of care, again, we couldn't roll up the total cost of care to the entire IDN. But the flagships whose IDN sponsored health plans were 20% more expensive on Medicare cost per case than their in-market competitors. The flagships whose IDNs did not have health plans were 8% cheaper. So with the limited budget that we had, what we were really trying to do was to start a database as opposed to a religious conversation about whether we want to continue fostering this form of healthcare organization. And frankly, that's what we think ought to happen. With the modest budget that we had and the difficulty in accessing information, we only scratched the surface. And yet, though there is a compelling, value-based case for building IDNs, we couldn't find the business case, either for the payers or the IDNs themselves. And I hope you won't consider this a snarky remark, but they're all nonprofit. Kaiser's nonprofit. I assume that if there were a compelling return on capital here, that we'd see businesses getting into this business. We'd find private equity investors creating them. The closest that we really came in the history of the IDN was Humana, which had a huge hospital company, started a health plan, and in 1993 concluded that the conflicts of interest between those businesses were irreconcilable and sold their hospitals. So we have had people that have looked at, is there a business here in a classic return on capital sense, and walked away. Our belief, which we'd like to validate with more rigorous and detailed analysis, is that the total cost of care per capita is probably higher in most IDNs than it is in their markets as a whole, probably higher, and that the Dartmouth Atlas information is a reasonable proxy for that. I believe the conflicting incentives, the idea of operating businesses that are diametrically opposed, that have diametrically opposed economic incentives, actually raises risks for investors, and that the disclosures that are made to bondholders are probably inadequate for those bondholders to evaluate the extent of the risk. There has been one major catastrophic bankruptcy in IDN space. That was the Allegheny Health Education Research System in Pittsburgh in 1998. And yet it's remarkable how little the disclosure requirements for these entities changed, even though billions of dollars in bonds just sort of went up in smoke in that bankruptcy. These are very wealthy institutions. Many of them have $3, $4, $5, $6 billion in assets, and when operating performance deteriorates, they're able to fall back on non-operating income as a way of, continuing to do what they're doing. We believe the public interest would be served by more detailed and illuminating voluntary disclosures by IDN's managements. We don't believe that mandatory public reporting is the answer here, and the things that we think they ought to disclose are where they're making their money. The P&Ls if they're major businesses, the extent of subsidy flows between those businesses, and also overhead allocations among those businesses, and also their MD compensation policies. I mean, if these entities are coordinating care across the continuum, but they're generating 90% of their profits from selling MR scans out the back door at $3,500 a copy, they're probably not in the coordinating care business. They're probably in the fee-for-service business. And similarly with physician compensation, if they're coordinating care across the continuum but paying their docs on an RVU basis, where the more they do, the more they make, they're probably not in the managed care business. So this was just a start. We intend to do analysis of the performance of these organizations, but it's remarkable how little public evidence there is that they're actually achieving the stated missions of coordinating care and reducing cost. So, time for the panel, right, Robert? Yeah. Right. Yeah. Yeah. Right. Right. I'm not sure that's a right, that's zero, which is obviously not right. Yeah, that's an error. Yes, it is. So it's a negative correlation.
Then say the more revenue at risk, the lower the average cost per case, if I'm looking at the graph correctly.
But that's not what we found.
Yeah, but my point is you found it because you're including the the one that has 0, which doesn't seem to.
Right.
Okay, and then my second question is, how do you reconcile these results with the evidence, for example, coming out of the AQC in Massachusetts, which admittedly is not about IDNs, but it's sort of kind of a virtual IDN, where putting entities more at risk, putting providers more at risk, does seem to have generated, by year 4, 10% cost savings, not directly through IDNs, but kind of virtual IDN.
Right. Well, the ACO is considered to be a virtual IDN. It's sort of like an IDN without the care managed, without risk. It's like gin and tonic without the gin. It's the highest cost market in the country. So the idea that there's low-hanging fruit that these organizations could pick by doing a more effective job, clearly there's an opportunity there. If you look at the ACO performance, and that was just in the New England Journal a day or two ago, the big savings seem to come from the high-cost markets. But what we're talking about is 30 years worth of literature on the subject and a really skimpy snapshot of IDN performance based on their public disclosure. I'm more convinced by the Dartmouth Atlas stuff, which is closer to the total cost of care. And I think it's also a measure of the moral, kind of a measure of the moral stature of a medical community. You've got families that are desperate, do anything to save my loved one. You've got scared people. And so if the value system of care coordination has permeated across the organization, you would expect the total cost of care in the last couple of years of life to be lower, not higher. So I'm more persuaded by the Dartmouth stuff than I am about our snapshot of the Medicare data. Right here.
Hi. So you clearly mentioned that this all looks like a black box when you try to figure out how it's all working on the inside. I'm interested in why, if that is the case, and you clearly say that more information would be very important, why is the recommendation or the conclusion that it should be voluntary disclosures? Like, what is the argument for not mandating more disclosure?
Well, who regulates these entities? The health insurers are regulated by state insurance commissions that actually do mandate fairly detailed disclosure. But who is responsible for evaluating the overall financial performance of IDNs? I'm not convinced that that's a viable state or federal mandate. I really believe that it is in the interest of these entities to demonstrate to us that they're saving money and improving quality, because that's what they're supposed to be doing. If they possess information that suggests that that is in fact happening, my argument is, let's see it. It's in their best interest, both from a business and from a public policy standpoint, to have that information on the table. Yep. Well, thank you very much.
So it's time for the next panel to come up. Sit wherever you want. Yep, wherever you want. Seat yourself. Wherever you want. It doesn't. Okay. Thank you.
Excuse me while I get my glasses on. Otherwise, I'm going to have trouble doing this. I'm Laurie McGinley. I'm the Health and Science Editor of the Washington Post. I'm delighted to be here. I see a lot of familiar faces from my wanderings through the various news organizations of Washington. So I'm very happy to be here, and I've heard a lot of things so far that I've found extremely interesting. We have a great panel here to help us dissect these issues and to add their voices and their points of view. And then we hope that you will also speak up after we talk for a little while. I'm going to do brief introductions. And since I haven't met all of you, I've met many of you, maybe you could just raise your hands to indicate who you are, because I'm not sure what order I'm doing this in. We all know Bob. John Colmers. John Colmers is the chair of the Maryland Health Services Cost Review Commission and vice president, healthcare transformation and strategic planning at Johns Hopkins Medicine. Chip Kahn, been around a while, president and CEO of the Federation of American Hospitals. Beth Feldpush is the senior vice president of policy and advocacy for America's Essential Hospitals. Matthew Eyles, am I pronouncing that correctly? Yes. Is the Vice President for Policy and Regulatory Affairs, America's Health Insurance Plans. Martin Gaynor is the E.J. Barone Professor of Economics and Health Policy at Carnegie Mellon University. And Karen Pollitz is a Senior Fellow at Kaiser Family Foundation. So since I am the non-expert on this panel of experts, I thought I would start by asking a very simple question. We've heard about a lot of problems already and issues about market power and pricing, especially involving hospitals and hospital systems. But at the same time, we know that in the last few years, as Bob has said, the hospital prices have moderated. Healthcare spending has, in fact, moderated, though there's a debate about whether that will continue. So I guess my question, which I'm going to put individually to each of you, so at least you get one time to say your piece on this, is do you think we face a real problem here? Do you think that there is a pricing problem, or are things going well and we should just leave well enough alone? And why don't we start with you, Matt?
Can everyone hear me? All right, great. Thanks, Laurie. What I'd first like to do is just commend NACI on the report. I thought it was an excellent report and a balanced treatment. It highlights a lot of really important issues. As representing the health plan side, I mean, our members are very acutely interested in delivering value, especially as we come into a more consumer-based market, and we're acutely concerned about prices. And I think it's important to separate the difference between prices and costs. And we continue to see significant price increases. It varies significantly across different markets, but we know that healthcare spending has moderated, but imagine how much lower it could be if the price increases were not as great as we've seen across especially the hospital marketplace. I mean, what we're seeing, if you look at the consumer price index really since 2000, you've seen a sharp inflection in prices in hospitals, especially compared to the consumer price index. And so we're very concerned about how market power is leading to higher prices and has a downstream impact on affordability for our consumers, for employers that are trying to provide employer-sponsored coverage, and it's something that we're acutely interested in.
I think that I'm not sure why prices have moderated. Obviously, some argue it's economics, some argue it's structural change, but I do know the following, that we need to be very careful about setting policy looking in a rearview mirror. And I think the study that was done and the work that was done was incredibly important. It showed many things, but in reading it, we have to be careful about looking at the past and projecting to the future. And the reason I argue that is because I think we're at a period now, and we've been in this period similarly in the past, where there's tremendous discontinuity in the healthcare system. And we have to look at it sort of as a system. And looking at hospitals separate from doctors, I think, and separate from the whole continuity of care is very problematic. But we just had a law passed 5 years ago that includes that is driving tremendous change. And that law isn't even fully implemented. And so I think, and then we had an SGR reform that just passed that goes into effect many years from now, but will also drive tremendous change. There's experimentation going on. There's institutions evolving, and there are tremendous pressures, and I could go through all the pressures, but you all know them as well as I do. So I think it is time now for caution, and the notion that concentration is a problem sort of flies in the face of Bill's whole notion of all politics and all healthcare is local. So we've got to be very careful now. And I will point out that I think that the study, as good as it is, took a very superficial view of the other concentrations, the insurer concentrations, and also the input prices that pressure hospitals from concentrations on the drug side, the device side. So I think there's a lot going on. It was a good analysis, but to me, now is not the time to do anything different. We've got a lot that's got to play out.
Marty?
Okay, well, with regard to your question, look, healthcare spending growth, not the level, but the growth has moderated. I'll take it. That's wonderful. Let's do everything we can to take advantage of that. Let's not take our foot off the gas pedal. The trick is figuring out where the gas pedal is on this. As far as sort of market power and high prices, let me say two things about that. It's not obvious that market power drives price inflation or rate of growth of prices, but that doesn't mean it's not a problem. There's lots of evidence that mergers between close competitors can lead to very substantial price increases, 10, 20, 30, 40, 50%, and once those prices go up, they stay up. So consumers are saddled with those high prices on an ongoing basis. That doesn't necessarily mean that there's continuing growth in prices, but that we still nonetheless have an ongoing problem. As far as policy goes, I'll be very brief. The ACA and really the entire healthcare system is built on as a body or even an engine built on a chassis of markets. That's true about really every element of our healthcare system, even including Medicare and Medicaid. They're not privately financed, but they are privately provided care. So markets are very, very important. And it's absolutely critical that we do everything we can to make sure they work as well as they possibly can, because if they don't, it doesn't matter how well designed the reform is, it's not going to be effective.
Karen?
I'm the non-tech person on the panel, and I wanted to just break the rhythm a little bit by thanking the authors and noting that they had dedicated this paper to our friend Andy Hyman, who was really a champion for research that would lead to improvements in the way our healthcare system works and also improvements in fairness and justice. So I think that's a wonderful thing and worth noting. I think this discussion about the decline in healthcare spending, and is that something that we should sort of rest our laurels on? Probably not. I think transparency, the principle of promoting transparency in this paper is critical. Everything we've heard so far is that we don't really know why healthcare spending has moderated. We're just kind of beginning to figure out what's gone on in the last 5 years. Jeff's presentation, there are a lot of black boxes in our healthcare system, and I think it is incumbent on all of us to promote more transparency, and when there's time to talk more about that, I think it's also worth noting that there is authority in the Affordable Care Act to command that transparency. It just hasn't been implemented yet. So hopefully that will show up as well. Just one other thing about market power, and Marty mentioned this, but I hope that as we discuss strategies for altering market power or harnessing it, that we will keep in mind that consumers, when they're purchasing healthcare, really aren't consumers. They're patients, and they're wearing gowns that don't close in the back, and they don't have any market power. And for that reason and many others that Bill and others mentioned. So as we look at trends, I think it's important to remember that there has been a persistent problem for many years that has not abated with this slowdown in healthcare spending. 1 in 10 people in this country have report that they have delayed or gone without healthcare due to costs. More than 1 in 5 when you ask only people who are in poor health, and that, of course, is who will be consuming the healthcare. And that is true, more true among the uninsured, but also true among people with health insurance. So I think as we talk about, what to do next, we have to be very careful to protect people who are sick from whatever it is that the market forces are going to do to try to, or regulators are going to try to do to moderate healthcare spending.
Well, I think it's certainly, an interesting time to see the prices leveling off right as we are implementing the ACA coming out of the recession. And clearly there's a lot of things going on at work and fascinating to watch it all play out. I think I would say that, in addition to all healthcare markets and prices being local, I think it's important to remember that even within a particular market, things vary greatly from one provider to another. So the hospitals that are members of my organization are really bound together by a deep sense of mission to care for vulnerable patients, the low income and the uninsured. And there will still be uninsured individuals in America, even in Medicaid expansion states. And so as we look at market trends or information coming out about competition, sometimes that really doesn't hold true for hospitals that kind of are fighting a losing battle to begin with, because they have patients that have not only more severe medical conditions, but are also facing a lot of social and community level challenges as well. And some of the incentives that are out there for hospitals or for purchasers don't necessarily hold true for these mission-driven hospitals that have these lower margins and, quite frankly, often see themselves placed in higher cost tiers or excluded from some networks because of not only their cost structure but the patients they are. So I would encourage us, as we discussed today and as folks look further, to think that even within a market itself is not homogenous, but there's very distinct differences in the providers within each market.
So I think we should be really happy that prices are moderated, and let's not look so dour and act so dour about it. Frankly, I've been waiting a long time for us to be able to be at a point where a large number of people are insured, and while we still will have the uninsured among us, it's relatively low. And similarly, if we are indeed at a point where costs are being moderated, that I think is a good thing. I do think that we have reached an inflection point. I do believe firmly that there are changes that are occurring in how care is being delivered, that overall price and overall cost does matter. And we are moving in some places more rapidly than others away from a volume-based market on value. Now, I come from a state that we're maybe not on the far end of the distribution here. Thank God Bob is here, but we're different than others, and are learning and experiencing that in a way. In Maryland, through our all-payer approach, we have moved to global budgets, and that is fundamentally moving I think the way in which care is being delivered, and we would hope that that is a sustainable change. I think it is important on the all-payer note to recognize that we can't look at this issue independent of one payer versus the other, that there are actions that Medicare and Medicaid take that may well have an impact on what charges are. Certainly we know that the markups, the difference between costs and charges in states varies considerably, and to the extent to which there are disruptions in the way Medicare and Medicaid pay, that may lead to an attempt to charge more elsewhere. But I'm happy that prices are down. I'm optimistic that they will stay down.
Bob, do you want to?
Just one to just pick up the last one. This seems to be more evidence that the, I think, oversimplistic notion of a cost-shifting hydraulic doesn't exist, or at least has been exaggerated. The notion that when Medicare puts pressure on hospital price updates, as it did in the Affordable Care Act, that hospitals just turn to private payers and raise their prices. This suggests that that is not the dominant response anyway. Like Chip, I'm not quite sure I understand what's going on. The second point I would make is that, and I'm also gratified that there's not a growth in price escalation, but the variations in the base across hospitals and doctors where I'm aware of the information. A lot of this has been produced by the late great Center for Studying Health System Change, which Paul Ginsberg ran for a number of years, which shows variations in what hospitals are able to negotiate of 500%. You know, some hospitals that are lucky to get Medicare rates and others that where there is documentation that they can get 400 or 500%. That's not the typical, but that does occur. And in one situation, I'm aware, well, for physicians, again, the center in some of its reporting found that physicians in Miami accept about 70% on the Medicare dollar in their private payments, and that there was one investigation of a medical group in the Midwest that was getting 800% of Medicare in its contracting. That is in the base, not in the rate of increase, and I think it does raise questions around equity and fairness. But with CHIP, I'm a little nervous at a time when the problem seems to be moderating and lots of other things are going on of jumping in too quickly. But the one area that I think we can be a little smarter in is in how we pay in these new payment models. And so I have been concerned about the payment models, for example, for accountable care organizations that accept your historic spending as the base without any sort of blending between that historic base and sort of the community average. A lot of the pioneers have pulled out of Medicare because they started as efficient and under that payment model were essentially let no good deed go unpunished. They could not get any rewards. And I've certainly seen that with private insurer contracting on shared savings, where if you had high prices and high costs to begin with, you had a much greater opportunity to share in savings. So I think there are practical payment policies that could be informed by these basic variations in payment and be changed modestly to reflect that.
Anybody want to respond to Bob before we move on? So we'll come back to, would you like to?
Just one quick thing. Without disagreeing about being very careful about payment, just the basic point about market power and pricing applies no matter what the form of payment is. And it's not a disagreement with Bob, but even if we move towards bundled payments or other forms of payment which seem like they're superior theoretically, they don't address the issue of market power. If a firm has market power, they elevate the price, whatever that price is. As a matter of fact, those new forms of payment have beneficial qualities that rely on pressure relative to costs. And if a firm is able to keep those payments up relative to costs, then there's not going to be any incentive properties associated with these. And so the potential benefits have been lost.
I guess I think it's much more complicated than that, because Bob is referring to public payment, which is regulated, and I think this is multi-dimensional chess. I don't think you know, it's great to say this is a market like any other market. This is not a market like any other market. Very few people in this market pay 100-cent dollars. In most other markets, they do. And, you know, that makes a big difference. And there are few markets where you've got so many people that Karen referred to who can walk through the door, and by law, at least in the emergency room, you have to provide service to them. And, you know, even, for example, you know, there are complaints about nonprofit hospitals, much more than mine, you know, buying physician practices. But, you know, in the physician practices they're buying, because of requirements of tax exemption, they now have to take Medicare and Medicaid patients, whereas previously, if his physician didn't want to take another Medicare patient, he could do that. So I think it's a lot more complicated than other markets, and we have to be careful about doing that simple market analysis.
I will respond very briefly. I'm not saying that this market is like all other markets. I think I very well realize, and economists analyze this, realize it. It's all markets are unique, and this is unique among markets. And there's been a great deal of research done on this by a number of people, myself included, which take that into account. That does not obviate the need for competition or the impact of competition on consumers.
So let's just stick with that for a minute. So I think everybody agrees that healthcare is a unique market, maybe among other unique markets. But so given that, what is the policy response if there are problems? How do you empower consumers in terms of transparency? For example, it seems as though there have been a lot of efforts, or at least some efforts, on transparency that either have not been very popular among consumers. They call up their doctor and say, where do I go? And that's where they go. Do we need to tweak the antitrust policy or standards? There are many policy options here. And so the overriding question is, what is the federal role here? What is the policy response? Should we stick with the state regulation? And that was just too many questions. So Karen, why don't you, is there a role for greater federal effort on this? And I would assume that you probably think there is. And what do you think needs to happen?
Well, I think there is a role, and I think it's in law now, and we just have to get around to doing it. And I think transparency is incredibly important. I think empowering consumers is incredibly important. But I think we should separate those concepts a little bit. That to date, we've talked about transparency in the context of so-called consumer-driven healthcare, which sometimes I call consumer-driven over healthcare. That we should just disabuse ourselves of the notion that consumers, that patients have any kind of real market power, and we shouldn't make that the focus of whatever our market strategies are. Too many people are getting hurt. People don't understand healthcare, they don't understand numbers, they don't understand insurance, and it's very, very difficult to navigate care decisions, let alone coverage decisions, and people just get hammered. So I think transparency is more about unlocking the black box that Jeff talked about. Our whole healthcare system is so proprietary. There's huge objection raised to releasing even basic information about, how many people are enrolled in a health plan and who's leaving and who's staying, and, all payer databases. There's an interesting discussion in the paper about, the pros and cons of all payer claims databases and the burdens and the costs that would create for insurers. And I'm thinking, well, okay, if it's burdensome for them, then we certainly don't want to be throwing a lot of information at consumers and say, well, you figure it out. So there is authority in the Affordable Care Act for health plans to disclose on a regular basis all kinds of information. In fact, there's a long list of provisions that a disclosure is required for, and the last thing on the list is anything else the Secretary thinks is important. So it's very broad authority to say, just tell me how you work. What claims are you getting? What's being billed? What are you allowing? What are you paying? How much of that is out of pocket for consumers? How much of that is out of network? There's this kind of disclosure could tell us a lot about how plans are working in practice. It could tell us a lot about what's the dynamic between hospitals, doctors, pharmaceutical companies. It doesn't need to be such a black box, but I think there's a reason, not just that, bandwidth is limited and there's been a lot to implement. I think there's been a lot of resistance on all sides to the notion of actually achieving this kind of transparency, that while this information is proprietary, both sides in the market struggle have advantages, and it will be beyond, I think, regulators, consumers, anybody, researchers, to kind of come in and referee that until we can begin to see more about what's actually being charged.
Let's switch over for a minute to antitrust enforcement. Do things need to change there? It's certainly become somewhat more active. What do you think? And what do you do about monopolies that already exist? Is there any way to unscramble the eggs? Or what's your view on that, Marty?
Okay, so I think that maybe coming back sort of to your original question, but focusing a little bit on antitrust, I think that one should be thinking of this a bit of a holistic way. And antitrust is one policy lever, and it's a very important one. I think I think as people know, the Federal Trade Commission has had renewed activity in this area, and I think that's been very productive and important. And I think there's a lot of activity more for the Federal Trade Commission, also the Department of Justice, to be engaging in both in healthcare provider and health insurer markets, not confined to one side by any means. But antitrust can do certain things, and there are certain things that it cannot do. So I think there are important roles for other players here. At the federal level, CMS and FDA are obviously very critical. It's already been mentioned what an important impact they have, but they can also take actions that, while they're not antitrust enforcers, certainly are related to market performance and market conditions. And there's been some of that around ACOs. CMS, DOJ, and FTC have collaborated very actively on ACOs, and I think more of that is in order. At the state level, to a large extent, state legislatures and regulatory bodies set the rules of the road. They determine what happens in these markets, and how much competition is even possible. In some cases, they do things that fortunately facilitate competition, but sometimes they do things that create impediments to competition, scope of practice regulations, any willing provider regulations, et cetera. So I think that there's no one player here, there's no one lever, and I think that it's important to have conversation, communication. We don't know yet exactly what the right mix is. I think the report was very valuable in trying to identify lots of options without coming down hard in one place on any of them, but I think there's a role for all these things. Let me say something very briefly about transparency, just two things. I think that, as was pointed out, it's not just simply putting information out there. You have to make it available or transmit it. I should actually say communicate it to individuals in a way that they can not just comprehend it, but they can actually use it. And that's a challenge. Two, I think that and that means not just price or cost, for example, but value, quality, other things that really matter to patients as well. On the cost side, we have to think a little bit about what transparency can and can't do. Even if people get the information, they understand it, they shop, people need to have insurance, and that means they need to be insured against catastrophic costs, and they should be heavily insured against those costs. That's really, really important. But that also means that when people, God forbid, suffer a very serious, costly illness, they're not going to be paying a lot of attention to prices. We don't expect that, and we shouldn't. Now, that's where most of the money is. So I don't think we should oversell transparency. I think it's a good idea, but it's one thing to be thinking about in a menu of policy levers.
I think we need to think about transparency at different levels, and Marty was beginning to hit at it. One, there's transparency for consumers. I think there's transparency for policymakers, which is really different and has a lot more to it in terms of the institutions. And finally, there's transparency for the marketplace, because at the end of the day, the pricing, the costing is irrelevant to the person who's really sick. The question I would have is, are the providers and particularly their broker, the insurer, in a position that they're going to get the best value for the bang for the buck for those sick people? And it seems to me in the marketplace there's got to be sufficient information for the insurers, for the providers. And I say the providers because we have devices and a lot of other areas where there's tremendous black boxes. So I think the market would work better if we had sort of on all these levels more transparency, but it's not the same thing. And probably at the consumer level, it's going to be their insurer, and hopefully, over time ACA will see that everyone is covered, and there will be an insurance product that will provide them the ability to understand what they're purchasing, and I think that's what Marty's describing.
And I would just add to that in all of this, we have to recognize that these are not monolithic institutions and cases. In price, in quality, in other types of information that goes out, there are very big differences in the institutions and the nature of the patients. So I tend to think that particularly in a world where I hope we are moving further away from fee-for-service, there is a greater emphasis on outcome and quality information, but even there, we have to make sure that we're taking into account legitimate differences that exist among institutions and populations that recognizes that it's not all one size fits all.
Yeah, and for the good of the order, I'll agree on the transparency notion. I am aligned with you, Chip, on that consumers need good information to make good healthcare decisions. And I know that a lot of our members are really trying hard to figure out what's the best way to communicate with consumers so that they can make that decision. We want them to have good information, and we're building all sorts of transparency tools to help give them information. But I think the point was made. Sometimes you're a consumer and other times you're a patient. And when you're a patient, you're really not in a position to be evaluating those decisions. And even when you have information to go in and say, make a decision about an orthopedic procedure or something that might be more on the elective side, things happen, and you really always can't predict what the ultimate impact of that experience is going to be and what kind of cost you're going to face as a consumer. But we're definitely supportive of making sure that our members and enrollees have that kind of information.
The question about is there an antitrust role when we already have consolidation going on in many places. For a paper that's going to be published one of these days, I actually found an article by Victor Fuchs, who's the smartest economist around, from 1998, who described a frenzy of merger and acquisition activity happening in the late 90s, largely in response to managed care driving down prices. And then Lemore Daphne, who's an antitrust economist from Chicago last year, used a word like frenzy. I forget exactly what it is at this moment. A lot of markets have already gone through that, and so it does raise the question of what do we do about extant monopolies, I guess is the technical term, and why some of us who would prefer market solutions do look at regulation. And perhaps, and this is not the typical case where you've got a powerful, at least oligopoly, perhaps a monopoly, who is using their market power to get 300, 400% of Medicare. But I think it deserves some scrutiny as what do we do there? And are there ways to actually get market entry to create competition? People are now talking about telemedicine and national markets for some services. But I think we do have to look at that issue, and there I don't think you do unscramble the eggs.
Go ahead.
Yeah, as a former antitrust enforcer, let me pick up on what Bob just said. For better or for worse, once a merger has occurred, it's not going to be undone. It just doesn't happen. And the problem is, to paraphrase Bruce Springsteen, once competition is gone, it's gone and it ain't coming back. So what do? It's a problem. In the 90s, the courts made a bunch of bad decisions with regard to healthcare mergers. They let a lot of consolidation happen. Here we are. So there are markets like Boston metro area, like Pittsburgh, like San Francisco that are dominated by one or a very small number of very, very large dominant health systems. Personally, I'm not a big fan of heading straight to regulation, but I recognize that there can be diverse opinions on that, and others may have different points of view that could be equally valid. I think that what we see in Massachusetts with the Health Policy Commission is very encouraging. The Health Policy Commission has the mandate to collect extensive data on every player in the healthcare system and to publicly report what's happening. And they were very influential in the resolution of the recent attempted Partners South Shore merger. The judge that ruled on that cited the Health Policy Commission's report 30 times. So that plays into something that we've been talking about with regard to transparency as well. I think sometimes a little sunshine can be beneficial, and a lot of sunshine can be even better. The other thing Bob said, I think that's very important, has to do with keeping the door open. There may be a very dominant firm, but if we can find ways to make it possible for others to get in and compete, then innovation can happen. And even if it looks like nibbling around the edges, sometimes markets can swing very suddenly the other way. So I think that's where the states, in roles of facilitating, hopefully, not impeding, competition, the ability to compete, as well as various elements of the federal government. And this includes the antitrust agencies because they do advocacy and policy, not just antitrust lawsuits as well.
We've talked a lot about provider consolidation, but I think we need to at least touch on the question about insurer consolidation because most markets are consolidated in terms of insurers. And I would just like to hear your views on how that affects prices and how that affects the function of the healthcare market.
Sure, I guess I'll start with that one. And I think that the report does a good job of addressing this issue and really highlighting that overall that insurer consolidation and market power is really not the problem. It's certainly an issue where we have, I think Bill mentions, some legacy areas where plans have been dominant. But what we've seen really is an increase in competition. And when we've opened up markets, insurers have come in. And if anything, we've heard complaints about too many choices for consumers and making it be too complicated. With respect to the consolidation that we've seen over the past few years, it's really been quite limited. And it's been more about building capacity, about diversification, and getting into additional lines of business, such as government programs, where insurers really weren't particularly strong in some area, rather than about market power overall.
Anyone else want to comment on that?
I do continue to worry about concentration of health insurers. I know in many markets there are dominant private insurers that represent 70–80% of the private market, and that does have an impact. So I don't know whether we can conclude that it's not a problem. I think it is a problem that we do need to continue to pay attention to. I also am concerned that the degree to which, with the moderation that we've seen in provider costs, whether that is in fact translating itself fully into lower premiums. And I think the evidence there is very unclear at this point, and I think that is something that does warrant further consideration by insurance regulators.
I mean, that piece, because insurers have, under state insurance laws, there's all sorts of rate review requirements and all
that
sorts
that vary quite widely from state to state.
That's true, but there's a lot more, and I think, as Jeff had mentioned, a lot more transparency about what's happening with respect to the insurance market and what's being required to be reported than what we see on the provider side.
I don't think we can be very encouraged about some of the premiums we see, though. So, yes, they're public, but yes, they haven't gone down despite what's happening in the market. I also think that, talking about disruption, we're at a potentially, and the King case could have a lot to do with this, but we are at a very potentially disruptive period in which the exchanges, assuming, depending on your point of view, we make it over the King case, I think will fundamentally change the insurance markets, because you're going to see a lot of employers over time, whether it's massive or mini massive, pushing people in there. And even though we can talk about the people having too many choices, the fact is there are usually many products, not that many insurers in these. And I think over time this concentration will affect that. And that, when you think about it, the entire individual market that we used to have is gone today. It is now in the exchanges. So where you used to have plans that maybe had high deductibles and coinsurance, but basically paid 95, 85, maybe 65% of charges if they had a good PPO, now it's United. Now it's a Blue Cross plan that people have. And I'm not arguing that the benefits value one way or the other, but the dynamic is changing. And I think as we look at this, we do have to be very careful about what happens in the insurance market, because that movement is changing the game. And I think that's sort of looking forward, not looking backward.
On the insurance side that we describe briefly in the report, which is the following: that if you are a very dominant health plan within a state, you have the ability to drive down prices, but you don't need to use it because you don't have any competition on your premiums. So you want the most favored rate. It doesn't necessarily have to be a low rate. Now, there are differences in how plans apparently do that. Everybody points to Blue Cross of Alabama as one of the really aggressive plans that is using their dominance. But other Blues plans, which also have 80 or 90% of the market, don't do that. And then in contrast, where you have very competitive insurance markets, and you do, the plans want to be able to negotiate aggressively, but they don't have the ability to negotiate. That's the catch-22 part. So they want to and can't, and the ones, so in any case, empirically, it doesn't seem that you get the same result of driving down prices, although my understanding, and this is quite secondhand, is that in the 90s in California, the competition amongst the health plans there were driving prices down and their capitated rates below variable costs, and were leading to some bankruptcies. So this could happen. It has happened, apparently, of insurers using market power in those ways, but that doesn't seem sort of why our wound up focusing mostly on the provider side. It's not like we ignored the insurer side. It just didn't have the same evidence base or the currency.
Beth, did you have a comment?
In some markets, some of our members have had real challenges in contracting with plans offered through the exchanges. And our concern is that that is maybe a reflection both of the services they provide as well as the patients that they serve. So many of our folks are higher cost providers because they are the hospitals that have not only large training programs, so very large physician programs, often training above their resident caps. They're also trauma centers. Most of them are level 1 trauma centers. They have burn units. They do transplants. They've got NICUs. They do all of the services that most of the other hospitals, if not all the other hospitals in their markets, don't do combined. So that raises their costs. And they're also caring for patients that often have lots more comorbidities or coming late into the healthcare system. And again, these are patients that were largely uninsured before and now have options for coverage through the exchanges. So we have definitely heard from our folks that they have either been excluded from exchange plans or placed into higher cost tiers. And I think our large concern is that we're talking about the very patients that really stand to gain the most from the Affordable Care Act and yet could be sort of priced out of those benefits. Because if you are a patient who was previously uninsured, now you have access to coverage through the exchange, but guess what? The provider that you've always been going to, whether it's through their emergency department, through a community clinic, they have a translator that will speak your language. They can actually provide you with transportation to the clinic. Those patients want to stay with those providers. And gee, isn't this great? They now have insurance that can help them with the cost of receiving care. But you know what? If they want to stay with that provider they have that established relationship with, they have to pay a higher price out of pocket than if they went to somebody else across town. So we're looking to kind of see how this plays out, but we're really concerned with the affordability of coverage for those patients that, again, really could stand to gain the most.
Thank you. And I think at this point we ought to open it up for questions. Is there someone who has a microphone, or are they just going to? Okay, great. Anyone have a question? Oh, sorry.
So if we have really competitive markets, what happens to some of the public goods that hospitals and maybe other providers now offer, in the sense of whether it's medical education or emergency preparedness or care for the uninsured? How do we handle that, and maybe rate setting plays a role in that for that purpose?
So I think, we sort of need to decide who owns the burden of those services and whether it's something that should be shared across all stakeholders, all payers, all folks. Then I think if that is our belief, then that would guide us towards policies in one direction or another. And if, that's not kind of the collective belief, then there would certainly be another solution. I personally think that there are some of the services which I just described, some of the, having the trauma care center, having the transplants, doing the burn unit, which, by competition, these are often services that you get better at doing these over time when you have a high volume. We probably don't want every hospital out there doing heart transplants. You kind of do want to concentrate that in certain places. I think that in many ways, my personal belief is that those types of public good, caring for continuing uncompensated care, probably can't be taken care of completely by the market, and then that's where we would look to other policies and regulations, either at the federal or state level, to sort of fill in the gaps for those services.
I will say that in Maryland, because of our rate setting system, many of those costs are either spread across the rates of all institutions or explicitly recognized. They all have to go through a reasonableness test. It's not a simple pass-through for those costs, but those are explicitly recognized in the rate setting system. So uncompensated care, for example, to the extent that it remains, is spread evenly across all of the hospitals, so there's not a price advantage or disadvantage for those by virtue of where they're located, and more importantly, where uninsured patients live and receive care. Those institutions are not adversely affected.
Just agreeing with what was said previously, ideal world, we publicly finance these sorts of things that actually are true public goods. Now, we have done that in part, and in part, for whatever reasons, we've relied on not-for-profit institutions to finance these things through net income, basically through profits. That's clearly an inefficient way to do things. If we can get away from that, that would be better. But I think that we do have to keep an eye on what happens to the least fortunate among us as we move forward, and make sure that those folks don't fall through the cracks.
Let me say, just in terms of our members, that I think ownership, whether it's investor-owned or nonprofit or even public, in most cases, I mean, our Medicaid numbers, according to MedPAC, are just as high as anybody else's. We obviously do as much uninsured as others. I think at the end of the day, a couple of things have to happen. One, and this may be a pipe dream, it really is essential that ACA work. I mean, that is a game changer in terms of one of the big factors here. Now, we still have, and I got to be careful how I say it, the immigrants, I won't define them, who are not covered, and we still have some populations that, regardless of, even in California, there'll be people who are uninsured, even if they, could be under other things. So, one, that's really essential. I think once you do that and make that work, and maybe in a California or New York, other places that will, then we have to begin, I think, to ask some really brutal questions about what role does should the public have in terms of research and education. And because I think over time there is a burden on Medicare that keeps getting pressured, and I worry, not that I think anything should happen to GME or IME, I'm all for let's keep the money there, that policymakers are going to look and say, well, why should we continue this? And so I think we've got to figure out a way to make that work, because we need the professionals, and frankly, the other side of it is we've never been very good at predicting how many we need under what circumstances. We've sort of muddled through, and I worry that if that we need to keep muddling through, because I'm not sure. So I think we need some of this extra money. I mean, in other countries, what do? I mean, I spent a lot of time in Israel. There the hospitals are chronically underfunded, but they spend a lot of time getting licensed research. They have all their researchers, and the hospitals get money back, and they have hotels and gas stations and malls, so they can fund themselves. But it's pretty tough. So, but we're not going to ever get there, I think. Hopefully, I guess maybe John Hopkins may have a gas station. I don't know. But we need to figure out a way to sustain these institutions.
No, we don't have gas stations, but we do, to the point that was raised earlier, we do have a managed care operation, so which actually provides a substantial amount of margin for us to be able to support our academic mission. And so I think that is something that's important. I do think that we need to look at different models of how we pay for medical education and research. It is one of the things that we're compelled to do under our new waiver, to actually look at GME, where it's provided, how it's provided. Are we training physicians appropriately for this new world? And we're about to engage in it. I don't know whether we'll ever get to the point of having it divorced entirely from payment. And to that regard, I think in answer to the question, we have to make sure that it does recognize those differences, because I think we all do want to have a future supply of people who are going to take care of us, and that we are funding research for new discoveries.
Let me just throw out a slightly contrarian view on GME, basically public subsidies for physicians. And it's not obvious that taxpayers should be paying for medical education. Doctors earn a lot of money. Most of the benefits from medical education accrue privately. They're not public benefits. And so I think this is something we do need to be rethinking, whether not just the form of the subsidies, which I think we'd probably agree are inefficient, tying them into payments, but whether the subsidies themselves, or at least at the levels they are a sensible thing to be asking U.S. taxpayers to continue funding. Because they, like anything else, that means there are some other things that we are not paying for.
And let's not forget, though, that a good portion of what we pay for medical education is IME, and that is probably much more reflective of the complexity of the patients that are being treated at these academic centers than it is for explicit training activities.
I'm Dr. Caroline Poplin. My question is about transparency. It seems to me that transparency isn't going to work very well, transparency of prices to the consumer, where everybody pays a different price depending on who your insurer is. The insurance companies and the hospitals in particular are very loath to disclose their prices because they don't want the insurer who's paying more to find out about the insurer who's paying less and demand the same price. Therefore, the opacity of prices is built into the system, and that's why you don't hear from hospitals what the price is.
It doesn't have to work that way. I mean, certainly what you said is true, but one thing that is happening is that I believe quite a few insurance companies, and Matt could speak to this, are setting up transparency tools for their enrollees so they can find for their plan how much would it cost them out of their own pocket to go here and there. Actually, I had a colleague who told me the other day, unfortunately, one of his kids needed an MRI for a head MRI because of an athletic injury, and it turned out that there was a $1,000 difference out of their own pockets they would have paid had they gone to one local place versus another. So anyway, that's not the point here. The point is that there are ways to do this that operate within that. Whether that's the best way or not is another question. Making this information broadly available so all competitors can see it can raise antitrust concerns. If it's held within, then it doesn't raise those kind of concerns. And actually, there are some programs like this for medical devices that I think have proven very beneficial to purchasers as well. So getting to Chip's point about various levels, it's not just about patients, though obviously they're critical, but purchasing is a huge area as well.
I think that was a really important question about was that in network, because and I've looked at the tool that my own insurer offers, and we just switched insurers under my husband's plan recently, so I was able to look at another insurers recently, and really not that helpful for people. But I think it does beg the question, why is one insurer offering an allowed charge of $1,000 more for this MRI provider versus that MRI provider? Why is the insurer doing that? And if the insurer doesn't have the market power to fix that, what am I supposed to do about it? So I think that if we're going to look to, I mean, it has always confounded me. How many prices must there be for just a chest x-ray, right? I mean, it's a chest x-ray. How many prices are there that are billed, that are allowed, you know, and why can't we look to, you know, Medicare, which has a lot of market power, or, you know, why do we have to have 1,000 prices for a chest x-ray? Could we just sort of observe, not so much for consumers, could regulators and policymakers? As Chip said, I think the transparency is not for me as a patient. I think it's for the policymakers to get a better handle on what is this dispersion of prices and why, and could we at least begin to set some limits, as Bob suggested, you know, maybe not go to a single payer, but, you know, could we at least say, well, okay, you know, Elizabeth Rosenthal had written about how MRI or colonoscopies in New York ranged from $750 to $8,500. Could we limit that disparity just a little bit and begin to, you know, kind of create a little more of a sane environment where patients certainly can operate, and maybe also learn more about, you know, what we could do to effectively limit costs.
Well, could we? Could we limit it?
With great danger. I mean, I think that this is a market, and we can argue whether you could construct a regulatory model that is as troublesome as it is to you, that will be as good as this market. And yes, there's tremendous variation, but, you know, it depends on how many insureds the particular insurance company is bringing to the game. It depends on, you know, whether it's in or out of network. There are a lot of factors here. We could do all away with that and just have a price list. But I don't think we would be satisfied over time with that price list. I actually think this is one area where the system works relatively well, except in cases, and where Marty makes points, where there's too much concentration on one side or the other. And I would argue over time that generally gets balanced out in most cities, but sometimes it doesn't. But I would be very troubled to think that in Baltimore, as much as I think everyone over there, you know, wonderful people work very hard, that they're going to come up with the great wisdom that's going to tell you what we should pay for everything.
Well, and as a matter of fact, for 30-plus years, through our rate-setting system, we've been able to do that at least for individual institutions, that it is the same price that is paid for all payers. And I'm, as you know, I'm not a proselytizer. I don't believe that this is something that is a solution elsewhere. But let's not suggest that it can't be done. It is being done, and I think successfully here, and we're transforming ourselves. It is not the solution for everyone. I'm the first to acknowledge it, but at the same token, we ought to be allowed to continue to do what we're doing.
I didn't say you shouldn't, but
certainly, obviously, Maryland and other states should be allowed to experiment. That'd be a great thing. I'm not as convinced of the success of the rate setting system in Maryland, but be that as it may, if that's a direction that the state chooses to go, then they should absolutely do that. But here I'm going to agree with Chip. I think the answer is more competition. I think things like price caps, basically saying you can't charge any more than that, we've seen from many other industries, unfortunately seem to backfire. I understand the frustration with this kind of thing, and it's not that something shouldn't be done, but I guess what happens, you say this is the most you can charge. What happens to prices? Where do they end up? Well, they end up at the maximum. That provides a focal point for firms to do, and it's very difficult to combat that. I do want to say something on these unexpected or surprise out-of-network charges, because they've been alluded to here, and that stuff is just totally outrageous and wrong. And a policy response is called for there. Something needs to be done. New York State has passed a law, for example. I'm not going to opine on how effective that law is or not, but this is something where there is a real need for this. What's happened is that more people have ended up in high deductible health plans, sometimes called consumer directed. I agree. I don't think they're truly consumer directed for many of the reasons that Karen said quite eloquently. And then so we're asking people to take more responsibility to do shopping, and some of them try, and they try hard, and then they have an anesthesiology bill or an ER bill that's out of network. They had no way to know they were going to get socked with that, no way to avoid it. That is completely counterproductive. It undermines the entire market. And this is something that really needs to be addressed. CMS, FTC, DOJ at the federal level need to put their heads together. States really need to address this, because if you undermine trust of consumers in the system, then it's just not going to work.
I couldn't agree more with Marty. I mean, we've been very focused on this problem of out-of-network charges, as you know, many of the people that are enrolled in our plans do their very best to go to an in-network provider and then just get socked with an out-of-network charge that is 8 times greater than what they would have paid had they been in the network, and they had no choice in it. And I'd say we think it's really important for the hospitals when they're in network to be disclosing this information that you might be seen by an out-of-network anesthesiologist or other provider. We need that kind of transparency to consumers so that they can make a decision, and it's just not fair to them.
Right, but the transparency, when I'm bleeding in the emergency room, I don't really care if someone's in network. I just need you to stop the bleeding right now. So I think the transparency could even precede maybe the price caps. Kathleen Sebelius used to talk about naming and shaming. You could just publish. This anesthesia practice only participates in this many networks, and on balance, they, balance bill this much every time they put somebody to sleep. This ER practice, does this. I mean, you could start by just publishing the information, not for consumers, more for reporters, more for, researchers, more for, folks who could begin to maybe, put this analysis to, to some better use.
I agree with everyone, and I think it's something that shouldn't be allowed. Everybody in the operating room ought to be rolling in the same direction. There is a dilemma, though, and I just want to get into the weeds for one moment, because there are many things that are going on out there which is making it much more difficult for hospitals and I would argue probably other providers to operate today. And I'll give you one example. On-call. In the old days, when you had when you had complete voluntary medical staffs, everybody who was on that medical staff felt it is my duty to do my 5 hours or 10 hours or whatever it is in the emergency room. And this particularly gets critical when we talk about neurosurgeons or orthopeds or arthropods or others. That is gone. We now have to pay for people to be on call. That's pay, and that's not reimbursed. And Medicare doesn't reimburse it. And they're getting paid a fee when they provide the service if they're a voluntary medical staff person. And I only say that because I think we're sort of a leaky ship in a lot of ways, and I wouldn't cascade the positions over this, but the old systems are breaking down, and that is one of the contributors, I think, to this problem, because if you're in a small town and you only have so many neurosurgeons or you only have so many anesthesiologists, you're not, as a hospital, even if you're a contractor, always in a position to say you have to accept the contract if we do. So I think this is a very complex problem that I think ought to be regulated. I'm with you. I'm just saying we got to be careful about problems we have out there which aren't much discussed but are very real.
I want to go back just a second to transparency, because we've talked a lot about the responsibility of providers as well as insurers to give meaningful information to patients about what their actual out-of-pocket costs are. But I want to make sure that we don't forget the potential role of states in this conversation, because those antitrust concerns are real. I've had a conversation recently with some of my members, and one of them really felt that it was the right thing to do to be more transparent with costs, and they kind of had this grand plan for how they could work with their community and put more meaningful information out there. And this particular provider is located in a farther western state that tends to have a more hands-off approach from the regulatory environment. And they kept going, my hospital kept going to the state saying, you know, we really want to put this information out here, but we're very deep antitrust concerns. We're afraid we're going to raise the tension with the FTC if we do that. Can you work with us on this? And the state just said, no, it's not, you know, it wasn't their priority at the moment. And so I think we need to just be aware that there is only so much that even willing providers and insurers can do to put that information out there if the regulatory structure is not working with them as well.
And with another question, I don't mean to break up the panel. I think it's been a great panel. I'm Jerry Shea with the Buying Value Project, which is a group of private purchasers, employers, union funds, business groups on health, all devoted towards trying to accelerate the adoption of value purchasing in the private sector. And this is only possible because of what's going on through the Affordable Care Act and the changes in Medicare. This in itself is fraught with a billion problems. But I want to congratulate the panel, and particularly the chairs, on providing us a report which, as Bob said, provides a topology that hasn't been put together before of options about what could be done here policy-wise, and I think the principles actually are a very useful framework. I think this report will be more helpful in the future than it is today, because I think we're going to get to these questions with a very sharper point. And I think we will get to the role of insurers here, and we've been talking about various aspects of this, chief one of which is transparency. Because what's happening on the purchaser, the private purchaser end, is we're still out there like we have no idea the quality of care that was delivered when we pay these bills. The bills come in the door, you know, we have some intermediary. The insurers are beginning to have quality purchasing kind of programs, but they're in the baby steps of this stuff. And that's what it is, and so we're going to have to sort of work on it. But the problem is, and I just want to add a little sense of urgency to the discussion, the problem in the end is private purchasers are throwing up their hands and saying, we just don't want to pay for this stuff anymore. You can pay for it, Mr. Worker or Ms. Worker, and your family. That's where this stuff is going. And so this is important in terms of sort of, you know, getting us some structures that we can look at so we can get some tools and get a handle on this, as complicated as it is. And, you know, kudos to the healthcare field for all of the change that they're trying to make. I mean, we've gone from, you know, very little attempts at quality improvement, a lot of talk about quality improvement for decades, but very little actual work, to an explosion of genuine quality improvement sort of activity. It will take time for that to mature. But in the meantime, we're going to wind up needing to do something to protect people against the high cost. I mean, the premiums going up, that's one thing, but it is the deductibles of the copays that are killing folks. And I'll just finish by saying, I fear that this same trend is going to wind up in Medicare, because we have a bipartisan consensus in this town that beneficiaries ought to pay more money to get their Medicare, that their Medicare is too expensive. And we're already at a point where we've introduced the income-related sharing for Part B, which is, you know, scheduled on a very big upward slope in terms of the number of people. So we're sort of going on this sort of like this crazy notion that we can continue to sort of figure out all the complex pieces within the delivery system and the insurance system, and, you know, we'll just in the meantime ask people to pay more money out of pocket. And this is nothing but people's wages or their Social Security checks. Take your pick, depending on whether you're an active worker or retiree. That's all this stuff is. It's deferred compensation, one way or the other. And so there really is, you know, the triple aim is getting a little bit lost here, because we're definitely on the higher quality track. With the lower prices, the lower cost track is, you know, still something we're reaching for out there. So, but I really want to congratulate the panel. I thought it was a great discussion, and also the entire panel that put together the report.
I guess this is time to wrap it up. Thank you all very much, and the panelists, you've been great, and we appreciate that you have all come and hope that you've gotten something out of it. I know that I've learned a lot, and it's been a terrific experience, so thank you very much.